perhaps than the doc, and to point out to your client, you need to call the doctor today about this one, or let's write this down, and next time you go, tell him about that. Being able to differentiate between those things is really important, and you might be on the front line of knowing those things long before a medical or a healthcare professional will.
It can be a primary manifestation of the disease, or it can be a side effect of the medication. And often, I mean, I know my clients have said, for example, they're feeling hyper on a particular drug, and they don't know why they're feeling that way or where it's coming from. So helping clients disentangle those and ask the appropriate questions of the medical provider can be very essential, just to help them understand what's going on with their body.
You know, I spend a lot of time training healthcare professionals, often substance abuse treatment providers, and they're all very fascinated about all of the different treatment options that are available. And just listening to you, Mark, the amount of information that is now currently available is so much to process, and obviously clients have so many of these concerns. I guess I'm curious about any other advice or experiences you know, people here have had on how in fact do we keep abreast of some of that information when in fact we have so many other counseling responsibilities, and perhaps even an issue of where do we draw the line around what is our counseling responsibilities with respect to some very, very sophisticated medical information.
And not only keeping abreast, but it's also helping our clients deal with differing opinions. I mean, all the time I'm getting, you know, well, I heard from Berlin this, my doctor thinks this, but my best friend's doctor says this, and people just really, it can become overwhelming.
Among many culture groups, herbs and other what is considered holistic approaches for them may be their choice, but is there a way to counsel them such that they can be monitored to say that at some point antiviral therapy could actually complement or enhance their intervention with holistic options that they choose?
Well, I think the real empowered patients, the ones that we have the advantage of taking care of, are combining a lot of holistic approaches with Western medicine, and they're going off and doing acupuncture or herbal remedies or compound Q infusions, etc. And we are monitoring them. We can't tell them that this is going to help them, but we can be sure that they're not going to hurt themselves. But I think that's all part of empowerment. I think the patient will do what I think he or she feels is going to help them, and if that's taking a piece from here and a piece from here, I think it's good advice. And
I think the first thing we have to do with our clients is to acknowledge that it is a maze. You know, acknowledge the fact that, yeah, the answer isn't there. Because clients always feel like the answer's there, they just don't have it. Someone else has it, they don't. And I think to normalize what they're going through emotionally, that in fact it is overwhelming, the answers aren't there, and that's frustrating. The uncertainty in all of this is very frustrating and that's the psychological challenge, I think, of living with HIV. And to acknowledge that, and then to help them move along with what's your philosophy, what's your doctor's philosophy, you know, how do you talk about that? And knowing that there are no really set answers. I think we as counselors have to acknowledge that.
I think that's wise advice. That, to me, brings it back to one of the original points you made, Mark, which was helping clients negotiate their treatment. And that, I think, is a very, very new concept, not only for clients, but certainly for me, speaking as a social worker, from our background in terms of intervening around the medical advice that might be given, and how in fact can we help clients work more effectively and efficiently and clearly with their providers, because we're often working with individuals who are coming from a background where the medical professional is the authority and what is said goes.
I think the one indisputable piece of advice that you gave is that people should definitely have a relationship with a medical provider. So that they can keep track of what's going on and be informed at each step of the way about what appropriate steps might be available to them, so that they're making informed choices.
I think a corollary to that, too, is, if you will, giving clients permission to change their health care provider.
That's what I was going to say,
because they sort of feel that once they've established that relation, or they may feel it's sacrosanct and the doctor knows best, when in fact you hear the underlying unhappiness, or that these two people simply aren't meshing. and just giving people the information that you can seek a second opinion, for instance. You can look for treatment that more closely follows your own philosophy of life and living, can be really helpful to clients.
I agree very much, Judy, with that. And let's acknowledge also there are physicians out there who really aren't as willing as others to engage in this kind of partnership. And I mean, just a piece of information from a study we did with long-term survivors with AIDS, many of them, a majority of them, had changed their physician early on in their treatment. But they ended up working with a physician that they trusted a great deal. They felt like it was a partnership. And that didn't happen automatically.
I guess building on that is the importance of the partnership and the relationship between the counselor and the medical provider, so that in fact it's not all second-hand type of information that we may be experiencing versus the opportunity to really work in that team approach that I think we all probably strongly agree that HIV really requires. Since the beginning of the epidemic, injection drug use has been cited as a key factor in HIV transmission. However, we would be remiss if we ignored the significant impact of non-injected substances, including alcohol, on HIV transmission and disease progression. The presence of alcohol and other drug abuse problems in an individual with HIV and AIDS simply complicates an already complex situation. Historically, substance abusers and their families have been regarded as tough clients because of the nature of the addiction and the multiple problems addiction often brings to the individual. Speaking on these issues is Billy Jones. Both a social worker and a certified addictions counselor, Billy is presently the Deputy Director for Community Prevention Training, a national project of the Center for Substance Abuse Prevention. Prior to this, he was Director of Minority Affairs for the National AIDS Network. Billy has also supervised several HIV-related projects for the Whitman Walker Clinic in Washington, D.C., targeting substance abusers both in and out of treatment, the incarcerated, and male and female sex workers. Billy?
Thank you. Thank you. Many service providers do not understand what substance abuse addiction is. Addiction is a disease or illness, an intake of alcohol and drug which causes imbalance, both physiological as well as psychological, and alcohol and drugs combined with enzyme, hormones, genes, and brain chemistry which causes abnormal and addictive behavior. There are many symptoms of drug or alcohol addiction. Some early symptoms are the ability to consume large amounts of drug or alcohol and still appear to function normally. Functional addicts, we call these, are not sick, not in pain, feel normal and at ease, have increased tissue tolerance, seldom gets drunk or high, and performance often improves in terms of work, sexual relationship. They often appear to be the life of the party, physiological adaptation in liver and nervous system. Some advanced symptoms are uncontrolled temporal violence, loss of weight, malnutrition, low white blood cell count, depression, anxiety, irritability, protracted withdrawal, and paranoia. Keep in mind that many of the symptoms related to drug addiction are also symptoms related to HIV/AIDS. Symptoms vary with type of drugs, extent of alcohol and drug use, stage of withdrawal, and the stage of recovery. It is important to understand the relationship of addiction to HIV/AIDS. Both AIDS and alcohol and drugs are biopsychosocial diseases. Both are influenced by physical, psychological, behavior, and environmental conditions. There's no single or simple magic bullet to either cure or prevent the occurrence of alcoholism or drug addiction or of HIV/AIDS. The risk factors of being mood altered and judgment impaired, the transmission factor of sharing injecting drug equipment, paraphernalia, and there are cofactors of the progression of the diseases in terms of compromised immune system, high stress, pre-existing illnesses, and also the transmission factor of pregnancy in terms of father to mother to fetus. At-risk behaviors of addicts for HIV infection are important to understand. That addicts share their booze and their bottles, their drugs and paraphernalia. When we speak of paraphernalia, it is not just the needle, but syringes, works, needles as well, or sometimes called hypes, cookers, spoons, dishes, cotton, filters, and waters. Addicts also share their sexual partners. It is also important for service providers to understand the relationships of drugs and sexual libido and the implications for safer sex intervention. Initially, early or limited drug and alcohol use, sexual desire, and performance may be enhanced. This is a syndrome we call ready, willing, and able. Later, sexual desire may be enhanced, but performance diminished. This is the syndrome we call willing, but not able. Men may experience impotence. Women may experience painful intercourse due to decrease of vaginal secretion. Eventually, sexual desire and performance may diminish. This is the syndrome we call not tonight, dear. Dysfunctional addicts are drugs become a substitute for sex until detoxification. This syndrome we call not sexually interested or active, except in cases of prostitution. Treatment options for drug and alcohol addicts include detoxification programs of 3 to 28 days. These programs may be either medical detox or they may be social detox. Also, treatment options include short-term residential treatment programs with an aftercare programs which may range 28 to 90 days, outpatient treatment programs with aftercare of 28 to 90 days, and long-term residential treatment programs with aftercare of 6 to 24 months. Other options include methadone programs, 12-step anonymous fellowship programs such as Alcoholics Anonymous, Narcotics Anonymous, Cocaine Anonymous, and Sex Anonymous. There's also social intervention program options, religious programs, work therapy programs such as the Salvation Army, and institutionalized crisis intervention programs which may occur in prisons. It is important for service providers to be aware of some treatment facts. That is that most addicts get well in a structured treatment program and stay well in structured groups. Also, that treatment and intervention for recovering addicts must be ongoing. Remember, like HIV, addiction is a chronic but manageable disease that is potentially fatal. 2/3 of addicts entering treatment programs get better initially.
Everybody is not strong like you.
However, only 1 out of 5 stay drug or alcohol free over a long term being 1 year or more, without at least 1 relapse.
If you don't want to stop using, go on.
Service providers can give very clear messages to addicts. Some of those messages are, number 1, get into treatment. Stop drinking alcohol, stop using all drugs. It is not unusual that an addict may stop using illegal drugs and transfer their drug use to a more socially acceptable drug such as alcohol. Therefore, prevention and intervention messages must address alcohol and drugs, legal and illegal drugs. Other messages include, do not share drug injection equipment with anyone. Assume that all of your drug partners and sexual partners could be infected. Sterilize all injecting drug equipment, including syringes, needles, cookers, with bleach or alcohol. And if possible, demonstrate the methods. Use condoms and water-based lubricants with all sexual partners. Stress the type of condoms and types of lubricant by brand names available to the clients in their area. Consider the merits of HIV antibody testing for medical intervention. However, remember, a diagnosis of HIV infection is not the same as a diagnosis of AIDS, and early awareness allows more options for intervention. Keep in mind, if relapse occurs, stress all of the above again. To not share is to care. Service providers should keep in mind to not preach, to not judge, to keep messages simple and clear, to be honest, to be patient, to be compassionate, to be firm and consistent, to avoid enabling and codependency behavior, to model healthy, drug-free behaviors themselves. Some elements of good treatment programs are educational tracks about alcohol and drugs such that persons in treatment will have a better understanding of their illnesses and be empowered to make informed decisions. Nutritional education information regarding balanced diet, vitamin and mineral supplements, and decrease in sugar intake. Keep in mind that sugar contributes to addicts' craving, depression, irritability, and tensions. Information about relapse prevention should include relapse prevention education as well as individual, group, and family counseling, which should include significant other and family couple counseling for gay, lesbian couples, common law couples, and domestic partners. Programs should also include HIV/AIDS education for all clients in treatment regardless of HIV status. Also included should be 12-step fellowship programs of AA, NA, CA, or other 12-step programs, or some ongoing follow-through support programs for recovery. We should also be looking at alternatives to drinking and drug use, such as recreational programs, culture activities, meaningful employment. Service providers can look at culture competence and sensitivity of services for addicts. Some points to keep in mind is that this is an opportunity to provide education about HIV/AIDS and alcoholism drug addiction. It's an opportunity to help change the high-risk behaviors that lead to HIV infection and alcohol drug abuse. It's an opportunity to make clients aware of a range of treatment options and availability of psychosocial support. It is also an opportunity to strengthen the skills and courage of clients to appropriately inform others of their dual diagnosis of HIV and addiction, thereby enabling them to gain support from loved ones and to not infect others or reinfect themselves. It's an opportunity to help clients accept the chronic but manageable diagnosis of HIV infection and drug alcohol addiction, thereby the possibility of a shortened but quality lifespan. Opportunity to motivate clients to use health and social services available in their area, thereby enabling persons with a dual diagnosis of HIV and drug or alcohol addiction to live as well and long as possible. It's an opportunity to make countertransference a useful tool in coming to understand the HIV-infected addict and furthering the objective of services, at the same time understanding one's own unresolved conflicts and problems that may hinder one's effectiveness in working with the HIV-infected addict. There are also some barriers to working with addicts, such as being overly critical, judgmental, and moralistic towards persons still using drugs or alcohol or persons who relapse. One way of dealing with this barrier is to learn to be directive and forthright about the at-risk behavior stemming from drug or alcohol use without attacking, without rejecting, and without putting down the person. Another barrier is the fact that active and recovering addicts may often be non-compliant, intentionally or non-intentionally, in regards to keeping appointments, making treatment protocols, etc. Again, be clear of expectations and instruction. You are a facilitator and resource person. When the client is at a state of readiness, compliance is more likely to occur, assuming the skills and means are in place. There's also the barrier of active and recovering addicts exhibiting high levels of anger, depression, alienation, and isolation. The client's despair and sense of helplessness can produce a similar despair in service providers. One resolution may be to maintain a nurturing environment that helps the HIV-infected addict to better cope with the life-threatening diseases and to lessen their fears of rejection and abandonment. Institutionalization of addicts in hospitals, residential treatment programs, hospices, prisons, often increases regressive behavior that is manifested in crisis-oriented outbursts that are impulsive and demanding. Addicts need an advocate to enable service providers who become angry with them to view them as frightened and vulnerable, to view their outbursts as reflections of fears that may have been hidden for years and not taken seriously, to understand their behaviors and reaction in terms of their feelings of helplessness and inadequacies, as well as their diagnosis of HIV and history of chemical dependency. Rather than falling into the trap of trying to problem solve for clients, service providers should be encouraged to joint problem solve and use techniques of problem exploration with the addict to help the client stay connected to the here and now, and to take one step at a time, and to elicit the feelings of the addict that led to outbursts. In summary, the keys to success in working with addicts are compassion for addicts' well-being, consistency of messages and presence, setting of limits and boundaries and structures, eliciting feelings, confronting antisocial behaviors, patience, patience, and patience. And thank you for your patience.
Billy, thank you for that presentation. I think you did a great job in showing us the parallels that we see with HIV as well as substance abuse. I think one of the things that I've struggled with over the years in terms of the issues of HIV and substance abuse is really, where do you begin? How do you prioritize the multiple problems that do exist, not only with HIV, but when they are complicated with substance abuse issues? And I wonder if you have any thoughts on the kind of the prioritization of counseling.
Well, you know, considering the dual diagnosis of someone that is HIV infected as well as coming to you with a chemical dependency problem or is also addicted, it's not one over the other. It's what we really need to do is to learn to assess that the person is coming to you with a dual diagnosis, and often multiple diagnoses. In addition to addiction and HIV, there are probably other things that are going on. I think being able to do that assessment and to identify that in addition to HIV complications, there's also the substance abuse complications, and then being able to make multiple referrals such that the person is gaining the range of services that that person needs. We also went through a phase where we, at some point, drug treatment programs were saying if you were HIV positive, then they would not take you in a treatment program. AIDS Service Organization were saying if you had a history of addiction, they would not take you. We can no longer do that. And so both AIDS service organizations and treatment programs are going to have to work with the person coming to them with a range of issues, and will have to work together. It does not mean AIDS service organizations have to become drug treatment programs and vice versa, but they will have to work in collaboration and as partners so that they can at least, both will have to be able to do assessments and then provide the range of services that the person needs.
We've had a lot of challenges around that ourselves at AIDS Services of Austin, and we've even looked at, well, do we need to have some sort of rule that says, you know, you can be a user, but when you come to this office to use our services, be it a Pentam treatment or food bank, you cannot be under the influence. And when we looked at doing that, we thought, well, there would be people we would never see because they were always drinking or drugging. But yet there are times when they're drinking or drugging that we can work with them because they're okay enough to work on social security, or they're able to discuss plans for their children, and by not allowing them to participate in our services because of that rule is really doing them a misservice. It ties into what you were saying. So I think, you know, we all have to challenge our systems as well as ourselves in working with people, and it's back to that point that I made earlier of starting where the person's at.
I mean, it really relates to the whole concept of harm reduction. And what we're really trying to do is help people take the best possible care of themselves and to help prevent the spread of HIV. And that means structuring our services and providing options to our clients where that becomes the real objective and not some other goal.
It also means being able to do an assessment of the systems and the agencies in the community to determine if they are able to provide the quality of service, but also have services such that they are accessible at different times than what we are traditionally used to, agencies being open 9 to 5. So typically what we've said to folks is you come during these hours. I think we are now at a time where we need to make our services more available for the range of clients that we're seeing at different hours. So having shifts, having night rounds, having drop-in services. So clearly, many addicts, if they're under the influence or using, may not be able to keep appointments, but they may drop in. They may come 6 hours later or 6 days later. They eventually will come back if they recognize that you are a supportive person for them. I think the key point when the client does come are those rules of setting boundaries and limits, having a structure there, but also what we need to get away from is finding reasons or setting up barriers to not provide the service to the client, and finding new and creative ways to expand the services such that we can provide the service when the client is there.
And one of the barriers, I think you mentioned, Billy, is sometimes subtle, but sometimes not so subtle, is our own biases and expectations. I think those of us who work in this field know that if we don't expect much from our clients, we're not going to get much in return. So we really do have to be in touch with our own biases. And too often we hear people not expecting substance-using population to come back. And with that, when that expectation is there in terms of from the care provider, it becomes a self-fulfilling prophecy, and they don't come back. When we expect things from them and get that message going, that we get much better results.
And sometimes it's that they're not coming back to us because we've given some messages to them that we really don't want to work with them, so they may go someplace else.
Exactly.
My experience in working with street addicts is they often will have their AZT or other drugs, they'll share it with each other. I'm out of drugs, do you have some? I mean, until I can get some. They're very creative, and they do try to take care of each other as well as themselves to the best that their addiction permits them to do. And so for us, it is one of being patient. And many communities now are beginning to look at that, such that when an addict comes in for a treatment program, they can also get many of the HIV/AIDS services, family counseling, and other types of services in the same setting, same surrounding, which makes it much more convenient for them.
Absolutely. I think we've seen a lot of those type of programs, or at least model programs, throughout the nation, and I think that seems to be the trend. When we take a look at healthcare reform here in the United States, the integration of substance abuse treatment services as a form of health care, whereas in the past we looked at substance abuse as being very, very separate, kind of out there, and those people were taking care of those problems, and then if you had a medical concern, you would go somewhere else. The need to bring those two together, I think, is a real important issue. Another piece you touched on was the issue of relapse, and I think that has some interesting parallels with HIV in general in terms of of course, many of us have been very concerned about the increase in sexual relapse amongst many of individuals. And of course, we talk about drug abuse relapse, and the understanding of the whole concept of relapse, I think, becomes an essential one in terms of being more sensitive to behaviors that we see exhibited by a client and not shedding our own particular biases on it. The sexual relapse component, the drug abuse relapse component, I think we're going to be seeing more and more of that, and particularly in addictions, we certainly look at drug abuse relapse as now part of the addiction process, and that it, unfortunately, in a sense, is to be expected, and we need to work with it, not simply remove somebody from treatment because they, in fact, have relapsed.
And also, I think one of the things that we haven't done very well is in responding, one is anticipating relapse. Relapse is real, and it does occur. In the past, we pretended that you should be able to get it right and just stay clean and sober. So we should educate people, the persons that may experience relapse, and that they can learn from each bout of relapse. What did you learn from that so that you do not have to repeat that? But the other part is, to the same extent in our safer sex messages, where we've talked about healthy sex and alternatives to unsafe sex and ways to be sexual and still protect yourself, we also have to talk about alternatives to drugs, because if you take away something that is pleasurable, you must substitute it with something else that is pleasurable. And that's the part I was talking about with recreational programs, culture activities, meaningful employment. But there are also other alternatives, and recognize that some persons are not in a state of readiness to stop their drug use. And therefore, some of those alternatives may have to include teaching individuals how to do drugs safely in terms of needle exchange programs. I know they're controversial, but they're real. Also in terms of bleach and cleaning works and all of those activities. We don't like to necessarily engage in those activities, but if that's what it takes to keep the person healthy until they're at a state of readiness to deal with their addiction, then we need to explore all of our options.
Too often we conclude that a client is resistant or in denial to explain what appears to be non-compliant behavior. Yet how often do we take the time to explore how cultural influences may have shaped such an outcome? Cultural competency is a term that has now become synonymous with effective HIV counseling. The diversity of people affected by HIV demands an approach that is sensitive to the unique needs of each individual client. But what exactly does cultural competency mean, and how do you integrate it into your counseling with HIV-affected clients and their families? Lana Ka'apua is an instructor of healthcare professionals with the AIDS Education Project of the John A. Burns School of Medicine, Department of Psychiatry in Honolulu, Hawaii. As a clinician, a teacher, a community organizer, and researcher, she has extensive experience in issues related to cultural competency. Currently pursuing her doctoral degree in social welfare, she is designing an instrument used to measure cultural competency levels. Lana?
Aloha e ko ma ho aloha. I greet you, my friends, with the sharing of the ha, or the breath of life, as though we were he alo, or face to face. I am grateful for the opportunity to highlight some of the issues related to cultural competency. In my cultural tradition, I apologize in advance if I offend you in what I am about to say. My intention is to speak with honesty about issues which are not always easy to look at. Stereotyping, cultural blindness, discrimination, albeit unintentional, on the basis of race, gender, socioeconomic status, or lifestyle choice. Each year, the AIDS quilt is assembled in Washington, D.C., and in states across the country, and we are given a chance to remember the names of those lives lost to HIV/AIDS. We are reminded that HIV affects us all. The virus does not discriminate on the basis of gender, sexual identity, lifestyle, age, race, or culture. By the same token, we are reminded of the diversity, including the cultural diversity, of those affected by HIV. Statistics tell us that a disproportionate number of people of color are affected by HIV, and that there is often an underutilization of existing health services. Ethnic minorities comprise 21% of the American population, yet comprise 75% of the diagnosed cases of AIDS and 80% of the pediatric AIDS cases. The underutilization of services by ethnically and culturally diverse peoples is not just a function of lack of access to services. This underutilization is often a function of the cultural unacceptability of services. By this I mean that health and mental health care services may be delivered in ways that functionally do not demonstrate respect for diverse traditions of help-seeking, healing, communication, death, and dying. So underutilization of health, mental health care services, including delayed treatment seeking, are issues of concern. Simply put, our services may not be the ones first sought by the culturally diverse client. And when the culturally diverse client enters our Western systems of care, early termination of treatment and failure to follow through with professional recommendations may occur due to cultural conflict. Herein lies the need for cultural awareness and culturally competent practice. Those of you who are readers of HIV Frontline, as I am, probably remember the East Indian story. If we had eyes all over our body and could see in every direction, there would still be one spot which we could not see. that would be the spot on which we are standing. In order to see that, we would need to step aside. Culture can influence the place on which we stand. In order to understand some of the diversity and cultural conflict that can arise in the healthcare setting, it is important to step aside and look at the spot on which we stand. Let's take a look at how cultural conflict might occur in the healthcare encounter. A well-intentioned healthcare worker tries to convince the caregiver of a person in end-stage AIDS that feeding must be stopped.
You know, she won't even eat.
Isn't she eating at all anymore?
No, she won't even try.
Well, you have to stop and realize that she's taking a lot of medication now, and it makes her real sleepy. And I know the doctor told you a few days ago that basically you could stop feeding her. So I think you really have to listen to what the doctor's orders were.
I know, but our family doesn't do that. You don't just stop feeding somebody you love, you know? I mean, that's not right. It's just not right.
Well, I know it's difficult, and if she's not wanting to eat, you just have to stop feeding her.
Cultural sensitivity is like motherhood and apple pie. Few of us disagree that there is a need to be culturally sensitive. Yet how do we translate the intention to be culturally sensitive into effective practice? The provider used her active listening skills. She attempted several times to explain to the caregiver why the feeding should stop, and even tried to allude to the possibility of unresolved grief on the part of the caregiver. Yet many of us view the vignette and speculate that the caregiver will probably go on trying to feed her sister after the provider leaves the home. What's wrong with this picture? There are values around diversity and entry etiquette that have been disrespected. There is an absence of listening for, eliciting, and using cultural information. There is an absence of eliciting difference, acknowledging it, and negotiating a plan of care. In many Asian and Pacific Islander and indigenous communities, respect for diversity is demonstrated by the observation of protocol. In Western culture, we might ask, "How are you?" In Polynesian and indigenous cultures, it is equally imperative to establish who you are in relation to the community. This is sometimes referred to as building binders. So if we return to the example in our video, Ruth, the provider, would have done well to spend time chatting, building binders, and gradually, but purposefully, moving toward the more sensitive discussions of illness, caregiving, and death and dying. Instead of Ruth saying, "The doctor said you need to stop feeding," she might have asked, "What do you believe is happening to your sister?" In negotiating a change in the caregiver's behavior, Ruth would have done better to acknowledge the aloha of the caregiver for her sister. She would have done well to remember that the sister may not be the only person with whom to negotiate. Stopping feeding might be a decision to negotiate with other members, perhaps more senior members of the extended family, the senior kupuna in the Hawaiian family, or perhaps the matai of the Samoan family system. This is where cultural competence comes in. Cultural competence builds on the intention to be culturally sensitive by identifying values, knowledge, and skills imperative for helping in the cross-cultural encounter. What exactly is culture, and how does it affect behavior in the helping situation? Experts tell us that culture is the accumulation of a shared pattern of values, attitudes, roles, assumptions, and behaviors that help us function in a particular context. The circle on the left represents an undifferentiated view of culture. Often we hear people talk about culture in a general sort of way. The circle on the right is perhaps a more precise way of seeing culture and all the various areas affected by culture, like sexuality and death and dying. What are acceptable practices? How do we talk about these issues? Using what words with whom? Like help seeking. What kind of help or healing is expected? How do we ask for it? What is expected from a helper or healer? Let's look at a few images and tease out the many ways in which culture influences our lives. I will use the Hawaiian culture, but really would suggest to you that concepts are cross-cultural here. The ancient Hawaiian elders had a saying similar in meaning to that of the East Indians. ku I ka ipuka o ko'uhale a nana I keao. Literally translated, from my door I stand and I see the world. What tells you that something cultural is going on here? What tells you that something culturally different to what most of us are used to is going on here? Perhaps it is the dress of the people. Perhaps it is the practices around which they are engaged. Perhaps you can infer from these images that working together or working with lokahi is valued. These are the more obvious things about culture. What might be less obvious is the high value given to process and interpersonal connection, which at times goes beyond the valuing of the outcome itself. What might be overlooked in the hustle and bustle of modern life is that many of these cultural rules of etiquette, like the time to make personal connection, are still practiced by many modern-day Hawaiians. The values of extended time, of a focus on the family, even the extended family, and the value of personal connection, or what is called binders, stand in contrast to some of the values of Western healthcare systems. Furthermore, for groups like the Hawaiians, there is already an extensive tradition of healing. The healing of the body, or kino, is not separated from the healing of the spirit. So for many of our people who enter more conventional Western health systems, there is a spiritual piece of healing that is missed, and perhaps bears exploration by the provider. The young boy you see before you is Bernard Punikaya. The picture was taken in 1937, just before Bernard was sent to the Kalaupapa Hansen's disease settlement on Molokai, one of the most remote areas of Hawaii. In his memoirs, Bernard recalls, "This picture was taken within a month of my incarceration at a hospital known by the euphemism Mount Happy Home. Upon the face of this child, I see the pain he is enduring. The loneliness is so overwhelming, Mama." The impact of Hansen's disease bears striking similarity to HIV/AIDS. The Hawaiians called Hansen's disease the mai ho'oka'awale, or separating sickness. Because of the stigma related to this disease, those affected were often shunned and treated as carriers of disease rather than as persons who were sick. Says Bernard, "They treated us like convicts sentenced for the crime of contracting Hansen's disease. Experiments were done without permission. The final degradation was the insidious belief that the disease had affected our minds. They denied me my rights as a patient, and then as a human being." It was not uncommon for people to regard being sent to Kalaupapa as a death sentence. Because Hawaiians were disproportionately affected by the experience of Kalaupapa, it stands as a historical marker. Many Hawaiians today remember and grieve Kalaupapa. Sometimes the remembering throws suspicion on Western healthcare and social services. This can be significant in the seeking of early detection and treatment of HIV. The nearly 100 years of forced isolation and discrimination in Kalaupapa is perhaps similar to the meaning of the Tuskegee studies for African Americans. It becomes part of the history of a people, and most importantly for our discussion here, may affect the credibility afforded health care and social services. Up to this point, we have looked at examples of ethnic culture, but culture really has implications beyond ethnicity. I stand at my door and I see the world. The culture of poverty and of homelessness can be pervasive influences on what is important to a person and how that person interacts with the world. How does being homeless color my priorities and what I value most highly? If what I value is survival today, how important is safe sex? How important is health care if I am basically feeling okay? If I do not have easy access to water, how am I to clean my rigs? If I have experienced feeling different in the healthcare system before, am I only likely to enter it if I really need it? And even then, with caution. There are numerous non-ethnic cultures that are relevant to our discussion, like the culture of poverty, professional culture, and the culture of Western healthcare. These cultures may influence the place on which we stand and see the world. Culture can affect gender roles. What do you see? From the place where most of us stand, we see a family. Now what do you see? The young boy sits proudly on the shoulders of his two athletic fathers. He wears a t-shirt that says, "I love my daddies." What is a man? What is a healthy family? A person may have multiple cultural identifications: partner, parent, athlete, African American, gay man. Any or all of these may be important to acknowledge in the health and mental health care encounter. When we make an assessment of the individual's cultural identifications, we avoid stereotyping. Where do I stand? What do I see? This man says it poignantly. On his tombstone, it reads, "A gay Vietnam veteran. When I was in the military, they gave me a medal for killing 2 men and a discharge for loving 1. Never forget." So what can we do to acknowledge diversity and be more effective practitioners? I would suggest that we have together just taken a key step in an ongoing process of looking at the place on which we stand. The video vignette you are about to see offers some concrete suggestions of how to bridge cultural difference. We revisit Ruth and see how she steps aside and does something different.
It's real hard for you not to feed her, isn't it? Talk about it. Tell me. What does that mean to you that she won't eat?
It's like, food is important. It's you get, we put our spirit in there when we make the food to give it to her, so she can get strength, knowing that we're here. And so, yeah, it's like, it's not there, and it's real hard.
Well, you remember the doctor said the other day that she's getting real sick and she's on so much medication that her appetite is just going to decrease and decrease. Do you remember that?
But we just cannot stop feeding her. We just cannot. That's just not something that we can do.
You cannot?
No, it's hard. You just cannot stop feeding someone. I mean, that's how people keep going. You have to try. It's important to try.
Yeah. And it feels better for you when you try too, doesn't it?
We all get another chance. And here Ruth the provider demonstrates some of the skills of cultural competency, including a willingness to really listen without judgment and a burning agenda, a capacity to acknowledge and negotiate difference. The micro skills of the LEARN model are important in culturally competent care. Respected teacher, healer, and friend Dr. Terry Tafoya has said that acknowledgement and negotiation of difference are often what is missing in the helping encounter. In summary, diversity occurs in the HIV-related helping situation and can be potentially problematic. It is vital to respect diversity by taking the time. Sometimes being with someone who is different from ourselves may take longer. Involving others. Don't be frustrated and confused alone. Flexibly approaching intervention. Not everyone needs the same kind of help. Eliciting cultural information. Withholding judgments. We may be standing at a different doorway than our clients. Seeking to negotiate differences. And most importantly, remembering that we all have a place in the world. Everyone has a culture. Thank you.
Lana, thank you. I think I'd be speaking on behalf of everybody here to let you know that was both moving and as well as eloquent. We appreciate that. A couple of points we'd like to focus on. One is perhaps a concern that I think often comes up with the fact that cultural competency is discussed so much, particularly in trainings with healthcare professionals, is often the concern of why are we focusing so much on cultural differences? Why not focus on cultural similarities that we all have in common? Have you had experiences in that question?
I think that's a very legitimate question, Jack. I think that HIV/AIDS brings on many similar kinds of experiences for people in terms of across cultures, we need compassion, care. Across cultures, we experience grief and fear and anxiety and depression. But how exactly those things are manifested in behavior, in action, in practices are very much culturally influenced. And so it becomes very important to look at and respect the diversity. I think one of the things we've learned is that colorblind services do not always work.
Okay. I think that's an important point to make. For me, also, I've experienced in a lot of the trainings that I've done with healthcare professionals is lots of confusion about some of the terminology that has now become, in a sense, somewhat buzzwords.
Yes.
And I think it might be helpful if we can clarify a bit more of how you've defined the differences between cultural sensitivity and cultural competency.
Okay. Again, I think that's a really important distinction because I think that most providers really attempt to be culturally sensitive. I think, as I said, cultural sensitivity is a bit like motherhood and apple pie. Mm-hmm. We all have the intention to be sensitive to the diversity between ourselves and our clients. However, the distinction between that intention and actual competence is that in cultural competence we look at a very specific set of knowledge, values, and skills that when integrated as a helping process assist us in working more effectively with clients who may come from a different place in the world.
Mm-hmm. And I would see that cultural competence is extremely important because some part of what we're trying to do as HIV counselors and educators and prevention experts is to introduce things into cultures that are not culturally appropriate, talking about sex and talking about stigmatized disease and getting families to embrace people with HIV. And so in order to do that successfully, we really have to know the culture and be competent in order to be able to help people move in their culture and be accepted.
I think it's helpful, Tom, for us to know about a culture. But the reality is that for some of us who are working in larger metropolitan areas, say, for example, in a clinical setting, that oftentimes, we don't have the luxury of knowing enough about every culture, and we don't have the luxury of being able to call a cultural consultant on the spot. And that's where the skills of competency, the values and the knowledge are cross-cultural. It is about eliciting information. It is about respecting other people's values and looking at how we can integrate a person's culture into the plan of care.
Yeah.
I think a part of that, too, is for us to keep in mind that we are indeed trying to bring about a paradigm shift within communities for the good of the nation as a whole as it relates to the transmission of HIV disease. And so if we're honest about it, we're trying to bring about some changes in terms of behaviors that cause the transmission of the virus, but also trying to be respectful of the community and being patient with that, for that shift to take place, because it can only be sustained if the community willingly makes that change because they understand the need for a change. And that would be true with any pandemic, whether it's substance abuse, whether it's HIV, whether it's sexually transmitted diseases. What we have to acknowledge is we have not been very good as a nation of respecting our differences. What we have done is come from a melting pot concept in which we have always placed emphasis that on we're all God's children, we're all just alike, we're all human beings. And it's not to refute, well, we could refute it, but that's not the point. It is clear that we have a lot in common, but it's also trying to stress that we also have a lot, we are different in many different ways, and that is also okay. But if communities can see a reason for making a change, they'll make it. But we have to be patient with that and teach that.
Mm-hmm. Well, I think the uniqueness and the breadth of those differences were brought out by you as well, Lana, when you talked about culture is not just ethnicity. Mm-hmm. And I think for many people who are working in the field, there's a sense of to be culturally competent means to be more sensitive to specific ethnicities, and we don't take a look at some of the other cultures that do exist.
Like professional culture, for example. You know, most of us went through a pretty extensive socialization process as we became psychologists or social workers or counselors or nurses or whatever. You know, a certain way of seeing a problematic situation, if you will, and assessing it and trying to define it and then resolve it.
Well, and that highlights the point you made that we all have culture, every single one of us. And in fact, that we all have more than one culture.
Yes.
You know, I have an ethnic culture. I also have a professional culture. I'm also part of the culture of being an HIV service provider and the
Yes.
culture of motherhood. And there's language and customs in all of those cultures that bring me together with other people who identify with that.
Good point.
I have a question that I don't know if it can be answered, but I think it's important to ask the question and for all of us to keep the question on the table. And that question is, are there any situations that the culture norms of the community or of a group take precedence to national health strategies that have been proven to reduce transmission of life-threatening diseases? And if so, is HIV such an instance?
Well, I think I would go back to what you said, Billy, and that is there may be national strategies, but those strategies really aren't going to be implemented in a community or sustained if a community can't accept the strategy and integrate it within its own value system.
See, I raised the question because is it possible that the government at some point could mandate a certain intervention for the good, what they perceive to be for the good of the country, and I think we have at times, that may definitely be counter to the culture of certain groups, whether they are religious groups, ethnic groups, community groups. And that will maybe impose, but will probably have resistance. I think it's a tough question and a tough response. I think the answer is yes, but I think we also have to monitor it really carefully. And so far, I think we're, in terms of this epidemic here in the United States, we are in a position of voluntarily developing strategies that specifically work, and also have come up with multiple strategy, comprehensive effort. But at some point, if they do not prove to be working in terms of really reducing the transmission of HIV, it is possible, I mean, that's the scary part to me, that it is possible that for the good of the nation, certain strategies may come in.
See, but I think that's one thing that we've learned with HIV, is that won't work either. I think that's been the big lesson of HIV, and that is that in order to effectively address a problem like HIV and many other problems as well, the only way to effectively work is with the community and from within the community. And that's a lesson I don't think we'll lose.
I think we've learned that from the lack of an effective national prevention campaign in terms of education, but I think when we look at treatment and counseling issues, I think we have a lot of work to do in that arena. I think the issue that you brought up regarding antibody test counseling for people with active addictions, and is that a appropriate message or recommendation at a particular moment that somebody is trying to, in fact, deal with their own addiction, makes us question some of the sweeping statements that, in fact, everyone, for example, should get tested or should not get tested. So I think we really are moving away from a widespread national messages and really needing to be a lot more specific and culturally specific. I think is really where we should be, and I hope we are headed. I mean, I think for me, Lana, what will stick with me in terms of your presentation was the piece around the need for us to step aside and take a look at where we stand. And that's, I think, a very important message that I know I'll be taking home with me. I want to thank you today for that.
Thank you.